for the opportunity to speak today. So we'll be shifting gears a bit, but I'm really glad that Dr. Manis explained all the basics. I'm going to get into a little bit more of the details, and it would be toward this idea of developing a personalized treatment strategy. Okay. So first of all, why would someone need a personalized strategy? So everyone's treatment can be personalized even right now. And those personalized issues from the patient's perspective includes personal considerations about what the treatment goals are for each patient and what the risk might be of those goals. So if the objective of the treatment is the maximum survival and the maximum response, then that may require that intensive therapy that Dr. Manis just described, and that may have a lot more side effects than the less intensive treatment option. The side effects of treatment, some patients would rather maximize their quality of life. Others might not want to maximize time with their family or time at work. And so each of these considerations would go into the treatment decisions. There are many different treatment options. So there's not, just as he was describing, a few options, there are many options today. So the question is always to ask what clinical trials are available for me, which ones am I eligible for, what of the approved therapies, what might be best for me. And all of that might take into consideration the patient's individual goals. He mentioned transplant. So for some people, transplant is intensive, even when it's the reduced intensity type, because it still requires being at hospital and or at the outpatient center for a period of months. Any transplant would require that. And there are different flavors of transplant. So the one that's called myeloablative, which means wiping out the bone marrow and the blood cells, that has a lot of side effects, versus the reduced intensity, may be more mild, but may not have may not be as successful in terms of maintaining that remission or achieving cure. So it's important to try to decide, would you be willing to do a transplant? And then you might want to ask your doctor, what's special about my leukemia that can be leveraged for treatment? So for example, we know we have specific inhibitors for some of the mutations that I'll be describing for you. And that being special may give you some other options. And then also what has happened to you in the past with your medical history that may limit those options. So for example, one of the drugs that we often use can cause heart toxicities. So if you have a history of heart disease, then we may want to avoid that. So you can see already that there's many considerations that can personalize anyone's options today. So I'm just going to go through a treatment overview, and again, many decisions to be made. So intensive chemotherapy is usually a double drug regimen. The most often one that was used, and it's been almost 50 years now, is called 7+3, daunorubicin or idarubicin, and a drug called cytarabine or Ara-C. And then even triple drugs or quadruple drug regimens are now also used as intensive therapy. And then there are non-intensive treatment regimens. Those include the ones like either decitabine or azacitidine and a drug called venetoclax. And those types of therapies became approved by the Food and Drug Administration a few years ago, and those have become quite common. And there's even a clinical trial now where patients can be randomized to get the intensive versus the non-intensive type of treatment to try to figure out which is best. Rule number one, initial treatment is not curative for the majority of patients. So you've heard that perhaps for some patients it could be curative, but important to remember that majority of patients, so over 80%, will not be able to be cured with the initial treatment. Depending on the age and the risk stratification, there may be better or roughly equivalent response rates for intensive versus non-intensive. And that's why we're able to even try to have a clinical trial to see which ones are better. And we don't have all those answers yet. The length of time before relapse might be shorter in the non-intensive regimens, but again, that would still needs to be examined further. And rule number 2, there are these risk groups that I'll be describing in more detail, the favorable, intermediate, or adverse, and those are associated with response and survival. So your course might be very different depending on the risk group that you're in. After that period of initial treatment, that induction and consolidation that Dr. Manis describes, then the question is whether to have a transplant or to not have a transplant. And just to remember that some categories of acute myeloid leukemia can only be cured with a transplant. So it's an important decision. Even the types of transplants can be individualized. There are many different types of transplants. Some of them have to do with the types of donors. It's important, the type of transplant we usually recommend in AML is an allogeneic transplant, which means that you have a transplant from a donor, and this can be a related donor, who could be one option, and an easy, perhaps an easily tolerated option is a matched sibling donor transplant, but only about a quarter of patients will have, or even less, will have a matched sibling donor. It's immunological typing, so it's not by blood typing. We can do transplants now with haploidentical, meaning half-matched transplants, and those can be siblings or children or parents, but still those are also relatives. There can be unrelated donors, matched unrelated donors, and we search through registries to find those. There's millions of donors on the registries now. And we can even do mismatched unrelated donor transplants. For example, 9 out of 10 matched at all those immunological types. We can use the stem cells from cord blood that's prepared from the placental blood. And there are volunteer donor cord blood banks now. There are different types of preparative regimens. So just like the initial therapy can be intensive or non-intensive, we also have that same ability with transplant. And then we have many different types of graft versus host disease prevention. Graft versus host disease is one of the major complications of transplant, and it's because the donor immune system, even though you're matched at the major immunological types, there are minor ones, and that causes some toxicity to the normal tissues. And we try to prevent that with medications that suppress the immune system, or chemotherapy, or removing the cells that we believe cause that. So again, many different types of transplants. So we've talked about the risk stratification, and this European Leukemia Net, or ELN classification, is the most frequent one that we are using. And the most recent one was just published in 2022. The favorable risk category includes a couple different chromosome abnormalities, breaking and reconnecting of chromosome 8 and 21, or a connection of inversion 16 to itself, called inversion 16 or translocation 1616, mutation of NPM1, a certain gene, and then there's also a mutation of a different gene called CEBPA. So those can be the favorable ones. And your doctor should be able to tell you, do you have a favorable type or not, based on just the usual analysis that's done at diagnosis. The adverse risk, the lowest part of this table, describes a number of different chromosome translocations or chromosome losses, those minus signs in some of them, and then having 3 or more chromosome abnormalities. And then there's a list of different genes. If those genes are mutated, then it's considered adverse risk. And that's at the last two lines of the table. And then there's the in-between, so the intermediates. And that's even including the ones like the people who don't fall into the top category or the lower category or the intermediates. So that is how the risk category is found, and your doctors can tell you about what you have. In terms of beyond that risk, you can see how many different mutations or chromosome abnormalities are defined. This was published in 2016, and it's just showing the in an extensive analysis of a large number of patients. It's showing the percent of individual patients who had those types of mutations. So the largest number of patients had this FLT3 or FLT3 mutation, the next largest NPM1 mutations. And you can see that the different colors represent those different ALN, ELN risk categories. And you can see that people can be in all the different risk categories and have the same mutations. So the mutations are kind of tracking different than the risk categories. But you can see just how many mutations there are. It was published in 2013 that each patient had on average about 13 different mutations. So because of this great heterogeneity, like all the patients seemed different to me and my colleagues. We were looking at all the patients and they had so many different kinds of mutations. And when we learned about that like 10 years ago, and everybody had a different set of mutations, no two patients looked the same from a genetic basis. And because we were watching patients have all different kinds of responses, and many of the patients, because so many of the patients relapsed, and so many of those patients relapsed even after transplant, my colleagues and I, University of Washington, decided that maybe we could learn about each patient, like try to get all the information we could about each patient's disease, and then try to give them something tailored to just them. And what we did was we took a panel of drugs and drug combinations, initially 160 and later 170 drugs and drug combinations. And we tried all of those. We took the patient's leukemia cells from their blood or bone marrow, and we put them in plates in the laboratory, and we checked them against all the drugs. And we were able to get these results within about 5 days. So it wasn't a really prolonged, I mean, a lot of other tests take about the same amount of time. So we also test them for 194 different genes that may be mutated. So we got all of that information, and then we tried to determine the best treatment for each one. And this is just showing like what those plates look like. So this little diagram shows all the different drugs being added with little tips into a plate that has 384 wells. And we could add all the different drugs. And then we added a luminescent probe. So luminescence is what fireflies have. So we added this luminescent probe that would show us if the cells were alive, then they would glow. And we had a detector mechanism to check what the percent of live cells were at the end of the incubation, 72-hour incubation. And each patient, then we could take all their data and see which drugs worked best for them. And this is just showing for the very first 30 patients that we studied, the compounds or the drugs are in the columns, each individual column, and the patients are in the rows. And you can see that every single patient, each row, so each patient looked completely different than any other patient. You see some patterns where maybe there's a little bit of similarity, but every single patient looks different. And that even reinforced our thought that maybe because everybody looks different, we should try to tailor treatment to them. Secondly, we thought, well, why are people responding or not responding to drugs? So I worked with a computer scientist and engineer on trying to determine of the 17,000 genes that we have, which genes are responsible for in that leukemia for causing drug sensitivity or resistance. And we found these 44 genes were with this machine learning, so an artificial intelligence mechanism. We found that these 44 genes were associated with either with sensitivity or resistance to entire drug classes. And red is that shows that the gene was associated with sensitivity, and the green that it was associated with resistance. And we called that the merge algorithm. We published that back in 2018. So then we went back to the patients and we enrolled 60 patients on a trial, and their ages range from 22 to 82. And most of the patients had intermediate or adverse risk. They had an average of 4 prior regimens, up to 8 prior regimens. About 40% of them had relapsed after allogeneic transplant, 40% of those within the first 100 days, and 22% of the transplanted patients never achieved remission. And then we looked at all the mutations that they had also. So these are the mutations that they had for which we had drugs. So then we tested the patients' samples against the drugs, and then we would add these, what we call targeted inhibitors, to them to see if that would work. And this just shows all the different regimens that we use. So as you can see, many different. So instead of just choosing like 6 treatments and the patients got 1 of 6 treatments, we actually looked at the patient and whatever drugs worked, and then whatever inhibitors looked like would be useful for them because of their mutations, we added them too. So you can see that all the different regimens the patients got and how many different patients got those regimens. And we were really thrilled. A couple of years later, when we looked back at the survival of the patients, we saw that the patients who received the recommended drugs, 35 patients received what we were able to receive what we recommended. Their insurance approved it, their doctors agreed, and that they had a higher 100-day survival and higher overall survival compared to the patients who, for one reason or another, were not able to get that treatment. But many of them got other treatment. They got CAR T cells therapy, immunotherapy, they got other inhibitors, they got other clinical trials, but we showed that this approach was helpful. And the right-hand panel shows the patients who had relapsed after allogeneic transplant, and you see that there's a big movement of the survival curve indicating much greater survival. So this is the fraction, the y-axis here is the fraction of patients surviving over the days after starting the trial. So big difference, and a lot of patients living several months. So the overall response rate was about 33%, but again, this is for multiply relapsed patients. And 95% of patients experienced a reduction in the blasts. One of the patients was alive more than 1,300 days, or now I think, more than 1,400 days after treatment. And we showed that assay-guided therapy could reduce the risk of death by 83% after controlling for all the other variables. So this is just to show you that it's possible to do this kind of thing, although it still represents the future. This was in a clinical trial. Our test is CLIA approved, so it's approved by the state of Washington, where the laboratory is, that we can use it as a clinical test and have done that. We've received samples from all over the world for testing. So I think this will be the wave of the future. And I'd like to thank you all. And later on, we'll have some time for questions.